Thanks, Ashish. Thank you for having me on this platform. Early in our experience, I just thought I'd keep it very brief with sharing a very difficult experience that we've had earlier this year. And this involves a 83-year-old lady who presented to a private hospital with acute flash palm edema with very raised biomarkers suggesting cardiac distress. Creatinine on admission was raised 1.73, quickly rose to 4.29. In that hospital, she suffered cardiac arrest, repeated cardiac arrest around 3 times, and had a successful resuscitation. She was intubated, extubated, and then reintubated, ventilated. She was anuric on vasoconstrictors with a creatinine rising to 5. At that time, we transferred her to Bridge County Hospital after having had a long chat with the relatives. On admission, her systolic blood pressure was 90 millimeters on a low dose NORAD with a pH of 7.1, metabolic acidemia with creatinines of 5.7. This, though the blood pressures were a little better with a high dose of NORAD, we corrected the acidemia. And you can see the chest X-ray that is for review there to the left was looking thrash almost. With an aortic, with the 2D echo showed a severely depressed LV function with the aortic valve area of around zero point 0.4 centimeters square and a gradient of around 110. This unfortunate lady, being anuric, we had our challenges were many, and some of them were that it was just difficult to do a CT for her with that anuric status, and we were clear that she would require dialysis post procedure. So we had to discuss that with the family. Our discussion was mostly revolving what the options. One was to leave her alone, which is what the family didn't want. And our choice was to either do a balloon dilatation and get her back for a possible TAVR later, or just go ahead and do an emergency TAVR. Now, this was, we took her to the cath lab. We took just 2 brief pictures with the right coronary artery, showed some moderate lesion in the mid segment, though not critical. The LAD seemed okay, though it wasn't it was selectively, the catheter selectively cannulated the circumflex, but much of the LAD was visualized in that little brief spell. And we did a detailed 2D planner and T, and based on the T, we figured that we got 2 diameters. One was 19, the other was 21, in these various mid esophageal long axis view, as well as the and the other cuts, the annular face. We did not have 3D T at this time, but based on the the represented data, we thought that we were safely right within the 23 valve segment, and being comfortable. My partner Ganesh Kumar, who actually presented earlier, and I could not attend that, but we discussed this, and we were very comfortable with using the 23 Sapien valve for this patient. Our accesses were okay. Most of our accesses are ultrasonic guided, so we had an ultrasound guided puncture. We didn't see any calcium at the puncture site, but our wire positions were okay, and we decided that the right femoral axis was rather favorable for the 14 French sheath delivery, which we went on with. And you can see our first this is our 3rd injection of contrast. We used around 10 ml, 2 injections, one for just getting and confirming the transannular plane, the coplanar angle. Once we crossed, we had positioned our valve, and we were aiming for 80-28, 90-10, if at all, keep it as high as possible, because on the echo, we could see some flakes of calcium in the LVOT. This is where we deployed it at pacing at 150 was enough. We just stopped on inotropes at that time. We completed this. It was a slow dilatation of that aortic valve. And we totally used around 40 ml of contrast for this, sealed the groins. And this was the final one little picture that we were wondering whether to do it or not, but got tempted and seduced into doing it. This was the echo. Post, she improved her ejection fraction, improved, her gradients improved to less than 10. There was no paravalvular leak. This was the lady day one, and sorry, where is that? This was her on day one after the procedure, followed by day 4, she was extubated. In spite of a complete hemodynamic recovery, she continued to remain on dialysis. Unfortunately, at the end of 12 weeks, she developed high grade fever and then succumbed to sepsis. But this was at home, and that was the that is the that was my worst case this year. And thank you for this patient listening, and I'll be happy to kind of get comments for.
And I think, thank you for sharing. Number one, we've all been in circumstances where we end up getting pushed. But the couple of comments. Number one, you could have done a CT without contrast for getting your access. So you don't have to depend on your fluoroscopic image just at the level of the groin, number one. Number two, I know you did this earlier in the year, but you have the ability to use 3D on the Philips and even the Siemens echo machine now. So you're not relying on the explained 2D measurement, which in this case was okay because there wasn't much ellipticity in the aortic annulus. But we all know that a minor and major axis can be misleading, and hence a 3D annular area, which could be easily obtained with echo, would be the way to go to be more accurate in the sizing. Obviously, you guys were right on. And the last thing is, we've done and reported and published with using zero contrast, both in the entire workup and during intraprocedurally. So if you, I know it's tempting to take a coplanar angle and things like that, but if you are able to line up your valve based on just using TEE, and if your TEE imager is experienced with a little, maybe a inflation of less than one atmosphere, just the tips of the balloon inflates, and that allows enough of contrast opacification for the imager to differentiate the tip of the balloon from the tip of the stent frame. And just because of the difference in the echogenicity, and you can land your TAVR valve very accurately without using any imaging at all or needing any contrast. So that's one of the other tips and tricks that can be done, and you can get a whole. But the bottom line, though, is that the reason for patients developing renal failure post-contrast is so much more than just the contrast and just the hypotension. And obviously, her goose was cooked from her 3 cardiac arrests and being anuric going into the case. So I don't think this would have altered the trajectory in your case, but this is an option for patients who have CKD 2 and 3 that are going into a TAVR rather than in this specific instance. So those were my comments related to your case.
Excellent.
Thank you, Ashish. Hey, I think, Kirti, if this is your worst complication, really, that's a fantastic job on your part. Okay, so I don't think that mortality related to sepsis is there's any way that it probably is from her dialysis or whatever exposure that could have happened. I don't think that any of us could prevent such a mortality. And obviously, when the patient is paying out of pocket in India, 30-day or 1-year mortality, I'm not sure how that actually is going to taken into the equation. Whereas in the United States, as the government is paying it, they want to make sure that the amount they spend is retrievable by making the patient live longer. So that's a different issue. With that,
we can talk a little bit about the case presented by Praveen. He talked a lot about Sapien in Valve and Valve. And Ramesh, I want to get your perspective on that, because I think, one of the things that 2 points. One, both Valve and Valve and the bicuspid case were interesting cases, and both have a slightly higher risk for, at least a numerically higher risk of stroke in the observational data in the STS-TVT registry, and as well as anecdotally. And a lot of people who are believers in embolic protection consider using Sentinel in both those circumstances, especially if you have to do any kind of leaflet altering therapy with either Basilica in the case on the aortic side, or Lampoon on the mitral side. So my point being, how many of you would have considered using embolic protection if that was available in those cases? And the second point was, one of the really important measurements to make in terms of when you do a CT scan that I don't think Praveen mentioned, I'm sure he does that, was something called the VTC distance. And what that is it's the valve to coronary distance. And unlike in the natives where you have numbers like 10, which is sort of like a arbitrary dichotomous cutoff for native valves, in the Vivid registry, Danny DeVere and his group suggested a number, especially on patients who have small annuli. A VTC of anything less than 3 is a high risk of potential risk of coronary obstruction, which is also higher with valve-in-valve cases, and especially if you're going to frac a small annulus. And so those were my 2 comments related to the bicuspid and or the valve-in-valve case on the aortic side. The last thing, of course, being, a lot of us are, for these valve-in-valve cases, putting in self-expanding valves because of being supraannular. You end up getting larger EOAs and lower gradients, albeit at the cost of potential risk of coronary access being a little more difficult with the Evolut R prosthesis. Those were my comments related to those 2 cases.
Yeah, fantastic comments. I think a VTC is very important for all the patients that are going to undergo valve and bioprosthetic degenerative cases. And VTC less than 4, I think we have to always be very careful about coronary obstruction. Here we started using a little less of Sentinel. We were 100% Sentinel use before. Now we are actually kind of looking at how to aortic valve calcium score. Then we are using Sentinel, as well as obviously high-risk degenerative cases. We are also using Sentinel, as you mentioned. The other point is fracking and coronary access, future coronary access, definitely determines what type of valve you should use. If there's coronary access problem, I think okay.
You're breaking, Ramesh.
Yeah, Ramesh, I think you're driving or you're on the road, so we're missing a lot of what you're saying. It's kind of becoming choppy.
How about now?
You'd have to
A
just
little
wait
better.
in one location.
Yeah.
That's be the best way.
Yeah, sorry. Okay, I think future coronary access also determines what type of valve you use, and we have used both Sapien and Evolut in degenerative valves, and I think we are probably about 50-50. I don't think that there is any excess use of one valve or the other. But having experience in both the valves is good, but we should use whatever you're comfortable with.
And the other point is, when you do these CT analysis, and don't completely rely on the valve-in-valve app, because Vinny Bapa hasn't updated that, especially on the mitral side. And so some of the information on the valve-in-valve app is a little outdated. The app is up for a revision and a version 2 that is going to be coming out in the next few months. I think by the fall of this year, he's going to have a completely revamped app, which I think will be reliable. But for the most part, I think focusing on what the internal diameter is of these valves, and also focusing on whether or not the leaflets are sewn on the inside of the stented leaflets or on the outside. So that'll make a big difference. And then there are certain red flag type of valve-in-valve situations that you should all be aware of. For example, Toronto or a mitral flow are potentially high risk for coronary obstruction that you need to, freestyles especially. So you need to be super, super careful in those situations and be aware that those are landmines that you can fall right into if you didn't know about that or have the cognitive awareness before you started your case.
Yeah, the Sapien now has been approved in the United States for a valve in ring. So we recently had a session and where Vinny was mentioning how he's been updating the valve in valve app, including to include actually valve in ring. And obviously, as you mentioned, the lampoon for mitral, basilica for the aortic, we need to be aware and also get experience on how to do these for valve in valve cases. So I think we are running a little bit behind, Ashish. You want to go ahead with the next set of symposium, which includes, I think, Indian experience in self-expanding valve.